Welcome everybody to this session for the Sustainable Care Conference under theme 4, which is about care markets, how and for whom do they work, which I've been very happy to co-convene with Catherine Needham. And today's session 4B is about the paid and unpaid care workforce. And we're going to be starting today with a paper from Florin Vadean on the effect of employment conditions on English care home quality. This is the first of 4 papers we'll be having in this session. Over to you now, Florin. Thank you very much.
My name is Florin Vadean, and I'm a researcher at PSSRU University of Kent, and I'm presenting joint work with my colleague Steve Allan on effects of employment conditions on care home quality. Next slide, please. Is better paid, better trained care staff more motivated and delivers better care? Or are intrinsic factors so dominant that pay has little or no effect on staff motivation? These are questions we aim to answer in this study. While the quality of a care home will vary for many reasons, staff are likely to be an important factor, influencing both the quality of care through the technical aspects of care delivery and the quality of life of those they are supporting. Frontline workers in care homes are viewed as low-skilled, are low-paid, often at minimum wage, and have little opportunities for career progression. Staff working in long-term care often tend to do so to make a positive difference to someone's life, the so-called care motive, and tend to have high levels of informal skills. Yet, there are concerns that low pay and conditions can have a negative impact on staff motivation. Nonetheless, there is little evidence for England as to the effect of employment conditions such as pay and training on quality of care provided by care homes. Next slide, please. Given the importance of care staff to a care home, it seems likely that improving working conditions, either intrinsically or extrinsically, through wages or other benefits, could have a noticeable impact on the quality of a care home. There are already a large number of empirical studies, mainly from the United States, examining how staffing can affect the care provider's performance, particularly on clinical markers of quality. In England, a significant negative relationship between quality and both higher job vacancy and staff turnover rates has been found in a previous study by Steve Allan and myself. And another study by Collier and co-authors showed more generally that training has a positive effect on firm performance and is inversely related to the likelihood of firm closures. Next slide, please. We use data from the Adult Social Care Workforce dataset for the years 2016 to 2018, which is the dataset on care providers and care staff at both provider and employee level provided by Skills for Care. It is the main source of long-term care workforce intelligence for England, including data on more than 50% of the long-term care market. We used mainly the provider level data matched to Care Quality Commission or CQC quality ratings and generated average hourly wages for care workers as well as measures for training from the employee level dataset. We created an unbalanced panel of about 5,500 independent sector care homes for older people observed over the 3 years with a total of just over 12,000 observations. Nursing homes represented about 38% of the sample, the voluntary or not-for-profit homes about 12%, and the average size of a care home was about 41 beds. These were in line with national figures for England. Next slide, please. Care quality is measured using the CQC quality rating system, which is based on the MUM test. The system looks to assess people's experiences of care, and there is evidence from other studies of a significant positive relationship between the overall CQC quality rating of a care home and the residents' quality of life. The rating is centered on an inspection of the care home and is constructed around 5 key lines of inquiry, asking if the home is responsive to people's needs, safe, caring, effective, and well-led. Homes are given a rating for each of the 5 questions of either inadequate, requires improvement, good, or outstanding. The overall rating for a care home uses the same 4 levels and is determined from a consistent aggregation of the rating of the 5 key questions. Due to low numbers of homes having been given the lowest or the highest rating, for the analysis we used a binary variable indicating low versus high quality, meaning 0 if a home was rated as inadequate or requires improvement, and 1 if a home was rated as good or outstanding. Next slide, please. In terms of descriptive statistics, about 3/4 of care homes in our sample had a quality rating of good or outstanding, with relatively higher ratings for care homes without nursing and voluntary or not-for-profit care homes. Next slide, please. The average hourly care worker wage for a care home was weighted using the Consumer Price Index to October 2018 prices. The average wage for care workers for the sample of care homes was £7.85 and were relatively higher in care homes rated good or outstanding, as well as in the voluntary compared to the private sector care homes. Next slide, please. In terms of other job and establishment characteristics, we could also observe that slightly more staff had dementia and dignity or person-centered care training, while the staff turnover and job vacancy rates were somewhat lower in good, outstanding homes compared to inadequate, requires improvement ones. Next slide, please. In terms of methods, we employed multiple imputation techniques to deal with missing values, in particular for job characteristics variables. Moreover, in a model of care home quality, job characteristics like wages can be endogenous. For example, both wages and quality could be determined by unobserved care home characteristics, or we could have a reverse causality, where the wage level could be determined by care home quality. To assess the true effect of wages, we required an instrument that is correlated with the average hourly wage, but is not directly related to care home quality. Following previous studies, we used exogenous increases to the minimum wage floor as instrument for wages. Specifically, we used the proportion of workers employed by the care home being paid less than the future national living wage rate. We estimated linear probability models of quality ratings, and given the panel nature of the data, we run both random and fixed effects estimations. Next slide, please. Exogenous covariates included as controls are at care home level, the share of female staff, the care setting, whether the care home is with or without nursing, the resident type, if with or without dementia, sector, if private or voluntary, the size of the care home as measured by the number of beds, the staff to service user ratio, and the distance-weighted Herfindahl-Hirschman index as a measure of care home competition. At local area level, we included controls for care needs, for wealth, and labor supply. Next slide, please. We tested for inconsistency of random effects estimations as compared to fixed effects estimations, and this could not be confirmed, showing that the random effects estimations were more appropriate. Weak identification tests show that the instrument used for wages strongly explains average hourly wage, and there is no evidence of over-identification when including a second instrument, which was the spatial lag of pension credit uptake. Further, the inclusion of the one-year lead of the excluded instrument was not statistically significant at 5% level in either the random effects instrumental variable or fixed effects instrumental variable estimations, suggesting that the instrument was not correlated with quality ratings in an unidentified way. Our findings show that the impact of hourly wage on quality ratings is significant and positive, based on the preferred random effects instrumental variable estimation. And everything else being held constant, a 10% increase in the average hourly wage would increase the likelihood of a care home being graded good or outstanding by 7.2%. The effect size found when including all job characteristic measures in the regression, meaning also training, staff turnover, and job vacancy rates, is very similar. There is also significant evidence of the endogeneity of average hourly wage, with the non-instrumented results indicating a substantial downward bias of the wage effect on quality. We also found that each of the two types of training had a positive relationship, while staff turnover and job vacancies a negative relationship with care home quality when included individually in the model. When included all together, only dementia training had a direct association with quality ratings. This may be due to the rather large number of people with dementia among care home residents in England. Next slide, please. Increasing the pay of staff and improving training provision in a generally low-wage sector would likely require increased public funding, as local authorities in England fund a large proportion of care home resident placements, in whole or in part. This study therefore raises important questions as to what is considered an acceptable level of quality and who should be able to access and ultimately pay for care that is beyond that acceptable level. We also like to acknowledge potential limitations to the analysis related mainly to the quality of instruments, but which we address by techniques and tests that are standard in the literature, and potential unobserved factors, like, for example, the share of residents self-funding their care, which we controlled for by proxies and fixed effects at care home level. And on the last slide, the usual disclaimer that the views expressed are entirely those of the authors. We thank the National Institute for Health Research for funding this study, and I thank you very much for your attention.
Thanks very much, Florin. That was extremely interesting. We're now going to move on to our second paper, which is by Olivier Crasset. And Olivier's paper is called The Effects of Summer Tourism on the Home Help Market in a Seaside Resort in Brittany.
Hello, welcome in Brittany. I'm Olivier Crasset, a sociologist at the University of Nantes in France. In this paper, I'm going to address the issue of the seasonality of work in home help services. And this is a question that, to my knowledge, has not been dealt with so far in the sociological literature, at least in France, but which is well known to the field actors I met. It was while investigating about something else that conversations indicated to me that this topic was a concern among professionals. Serendipity is therefore at the origin of this paper. What do I mean by seasonality? It refers to the fact that a phenomenon fluctuates according to an annual rhythm. This variation being linked to natural phenomena such as weather seasons, but above all, to social constructions, such as the date of vacations. This question has long been addressed by sociology. Since Émile Durkheim or Marcel Mauss, we know that suicides, marriages, and food consumption follow a seasonal cycle, and that the organization of society is sometimes affected by this cycle. As for seasonality of work, it is well studied, for example in the tourism or agriculture sectors. But I have not found any publications on home help. However, it will be seen that seasonality plays an important role in some of the issues related to the home care labor market. After presenting the survey methodology, I will describe the territory are surveyed. Then I will show the tensions that exist in the home help market, and I will propose some elements to explain their existence. Finally, I will describe two of its consequences, among others. First, the deterioration of working conditions, and next, the evolution of the relationship between the profit and the non-profit sectors. Slide 2. This research is part of the PROFAM program, which since 2018 is interested in the work of helping dependent people, work being considered in all its forms, whether family or professional. Within this framework, I have investigated several subjects in the territory to be discussed, and whose name will not be revealed. Seasonality data were collected throughout the survey period, but the summer of 2019 was devoted specifically to studying this issue. To do this, I conducted about 20 interviews with actors in the sector, home help workers, nurses, social workers, managers of profit and non-profit services, municipal and officials, and shopkeepers. In addition to this, I conducted an ethnographic survey where I accompanied home helpers during their workday, participating in it whenever possible, which also allowed me to meet the elderly beneficiaries of the service and their families. The idea was to go through the whole organization of the work, from the social workers to the person being helped. Slide 3. The studied territory is located in the northwest of France. It has about 100,000 inhabitants living in about 50 municipalities, some of which are located on the seafront. Its economy is mainly based on tourism and the food industry. From a demographic point of view, it's an area that is aging faster than the French national average. The aging index climbs up to 3 in the areas closest to the sea, which is why the survey focused on them. Aging is linked to the aging of the local population, to which must be added the arrival of retirees who come to live by the sea. These people are often natives who return home after a career spent in other regions, or individuals who permanently occupy what was until then their second home. So the territory is one of the most attractive in France for the retirees. Climate change promises new arrivals because it's put forward as an argument to promote the territory to attract the elderly who are afraid to go to the south, too exposed to the heat waves. According to demographic projections, the aging process is expected to continue at least until 2050. These arrivals cause a gentrification of the coastal zone. Slide 4. At the national level, home help jobs are one of the 10 activities designated by the unemployment services as job under stress, i.e. where job offers do not find takers. Locally, the situation is made worse by 2 factors. Firstly, young families are no longer settling on the coast because of the dissuasive price of real estate, which is constantly rising, and the disappearance of certain services like schools. However, home help workers don't want to work far from their homes because of the travel costs associated with the use of their personal vehicles and breaks during the workday. Secondly, the home help sector competes with the food industry and the hotel and restaurant sector, which I said were important in the local economy. These sectors are accessible to a workforce with little or no qualifications, whose profile is close to that of home help. the need for a workforce fluctuates over the course of the year, following a rhythm close to that of home help work. So there's a scissor effect, i.e. an increase in the demand for labor in a context where it is less and less available. This situation creates very strong tension in the market for home help in coastal areas throughout the year. And it sets the context in which the question of seasonal fluctuation in work arises. There are more needs. School vacations are critical periods, especially from the spring when residents of secondary residences with an average age of 65 years and 31 of them above 70 years. And when these people arrive, they call on home help services. There are mostly elderly people who come to spend the summer season at the sea and ask for help, whether they are dependent or for comfort services. Another phenomenon contributes to increasing the demand for care during vacation periods. During their summer stay, children of elderly people living in the territory come to visit their parents and sometimes become aware that their need for help has increased since their last visit. As a result, some of them submit a request or a reassessment of the assistance plan and are immediately looking for solutions while waiting for help to be put in place by the social services. So a peak in the demand for assistance appears in July, August, when the social workers are sometimes on vacation. The home care sector is not the only one that is under pressure in the territory. The hotel and restaurant sectors offer more jobs than there are candidates to fill them. Home help is a sector that offers poorer working conditions compared to other accessible sectors with a low level of education. This competition is exacerbated during vacation periods when seasonal employment in tourism is at its highest. In addition, family rhythms affect the usual balances. Home help workers who are mothers prefer to look after the children who are on vacation, since the cost of childcare in recreational centers can be a dissuasive factor. And this problem is amplified for single-parent families. The scissor effect is thus reinforced during the summer months. Slide 5. This situation has consequences on several levels. I will develop two of them: the deterioration of working conditions and the relations between the profit and non-profit sectors. But other questions may arise, like giving up vacations for some tourists or the reduction of the care of the beneficiaries to a minimum. The working conditions of employed home help workers are deteriorating in several aspects. For these highly mobile professionals, the difficulties of car traffic increase travel times, parking difficulties, and cause significant stress. The situation becomes more complicated during market days or festivities where certain roads are cut off. It's then necessary to negotiate with the authorities to be able to access the beneficiaries' homes. Since the badges affixed to windshields have no legal value, free passage and the punishment of parking violations are left to the discretion of the police. The time span of the days is lengthened by the difficulties of circulations, but especially by the increased number of elderly people to be cared for. The very high rate of part-time contracts, which is 91%, makes it possible to increase working time to reach that of a full-time employee during critical periods. In this context, the question of vacations or sick leave replacements poses serious problems, and some employers encourage employees not to take them in the summer. The moral obligation to provide service, which is completely internalized by the vast majority of professionals, pushes them to go beyond their limits, and the psychological risks leads to burnout and high turnover. Since 2006, the home help market has been open to competition. Public and associative services are not in position to absorb additional work. Demand is therefore shifting to private companies that are easily used by the wealthiest people, especially those in second homes. But the lack of workforce does not allow companies to meet all the demands. The public, associative, and private sector actors manage the shortage by coordinating their actions to focus on the most problematic situations. Continuity of care often means breaking the rules. For example, a company that cares for a non-dependent elderly person continues to do so when that person becomes dependent, even though it's not authorized to address this public. This situation, which is supposed to last as long as the assistance plan is put in place, continues, while at the same time the enterprise is under the threat of sanctions for deviating from the law. This example shows that the private sector does not disengage itself from the more social part of the work because it's involved in a local network of professionals guaranteeing the respect of certain values to which the private sectors remains attached, like a bad image of those who make profit from fragile people, a strong sensitivity to social inequalities, and a left-wing political culture. While wealthy people in secondary residences have relatively little difficulty in finding the services necessary for their health and comfort, some members of the working classes are now giving up their vacations on the territory. This first sign of growing social inequalities is not alarming insofar as the phenomenon only concerns leisure, but its amplification would affect the care for the poorest dependent people living in the area all year round, if economic logic creates a competition between these social groups. The difficulties encountered by public services and associations encourage the development of activities by private companies, which are more responsive and more flexible in their management. Even if most of them show real concern for the well-being of their clients, their presence reinforces an economic rather than a social logic by devoting part of their activity to the most solvent applicants. Conclusion, slide 6. Seasonality of work has very real effects. It contributes to increasing tensions in the labor market by reinforcing the scissors effect. The results presented here have limitations. They are based on the study of a territory that is not chosen at random. The phenomenon is very visible there. But the expected aging of the population in France may lead to the same situation elsewhere. In the territory studied, it will undoubtedly worsen in the coming years. Indeed, according to the interviewees, seasonality has been less noticeable in recent years because the labor market is now tight all year round. The situation today is that of a permanent crisis with peaks during vacation periods, summer, but also the end of the year and Easter. In this context, the seasonality of work is sometimes the last straw. Nevertheless, economic factors could play in favor of local development if we consider that offering services to vacationers is an asset for developing tourism, or at least for not discouraging them from visiting the region. Thank you for your attention.
We're now going to move over to our third paper by Amaya Alvarez, and this paper is called Choice and Control, Mental Health Carers, Marketisation and the Co-option of Unpaid Care in Australia. Thanks very much, Amaya.
Hi, my name's Amaya Alvarez and I've got a presentation on choice and control, mental health carers, marketisation and the co-option of unpaid care. I'm a PhD student at RMIT University, Melbourne, Australia. Before I get started, I'd like to acknowledge the Wurundjeri people of the Kulin Nation and their elders past, present and future. I'm sitting on their land, and I'd like to acknowledge that that land was never ceded. First slide, please. So the presentation today is going to talk very briefly about my research. I'm a lived experience researcher. I support someone with complex mental health challenges, and I'm interested in the impact of this new system of support, marketised system of support, the NDIS, on people like myself. So in the presentation, I'm first of all going to do a brief overview of my work. Not going to talk to it too much because I want to keep it at a fairly high view, and I can't go into a lot of granular material in 10 to 15 minutes. And then I'm going to talk about what is the National Disability Insurance Scheme, and I'll call it the NDIS from now on in because it's a bit of a mouthful. And then I'll talk about the positioning of informal supports in the markets of the NDIS, so where are carers and families and friends who provide, long-term support, weekly, daily, for people with disability. Where are they positioned in the NDIS? I'll draw on some vignettes of experience from my research to illustrate some of the issues that I can see coming up with this marketised scheme and some of the emergent findings and threads. Next slide, please. So my research project is looking at mental health carers' experience of the NDIS in the context of their everyday lives. And I'm really interested in the notion of the everyday, because from my own experience and the experience of people that I'm interviewing and researching, there's a real embeddedness and embodiedness to their experience, and that caring is not simply a series of tasks or activities, but it can take over someone's complete identity to the point at which they don't have any space to consider their own needs or their own futures outside of that. And we know that recent research on carers reveals they carry a heavy load, and research in the UK, Australia, Canada, Europe reveals this, and that it's only getting more complex and more intense. And it's a highly gendered space. Women do the bulk of this support, so that doesn't mean there are no male carers, but on the whole, structurally, it's women that do this work. And I'm interested in the everyday impact of the NDIS in this context, building from my own engagement with the scheme outwards and inwards. Next slide, please. But first of all, just really briefly, what is the NDIS and how does it kind of work? Well, it was established by the NDIS Act in 2013, and it came out of consultations with disability groups and organisations and people with disability themselves about how better to support people with disability in ways that gave them more agency, that were more empowering, that included them in the conversations. And there was a feeling that the old ways of providing support were a bit paternalistic. So it was piloted in 2013 as a scheme, and the full rollout occurred by the end of 2020. And my research has been going from 2017. So I've kind of been in the research and following the experience as I go along. So the NDIS addresses functional disability and insures against future costs. So it's an insurance scheme that says that if we spend money in the present on people's supports, their lives improve, and the cost of providing support to them will lessen as they become more engaged in the world. The NDIS replaces block funding to service organisations with individual packages paid directly to eligible participants. Now, to get into the scheme, to be a participant, a person must first of all decide to engage, which can be a bit complicated in something like mental health, for example, where people may not feel like they either have a disability or feel they want to engage in services because their previous experience has been so poor. So that's been a bit problematic. But anyway, they have to evidence their disability is permanent, treated and stable, and use the right language. So there's a language of disability here, whereas in the mental health space at least, there's a strong language of recovery, and that's been quite challenging for people to get their heads around. And to show that it's treated and stable, you have to prove that you've explored all options in the health system. So for instance, if you have a disability and there's a treatment available to deal with that disability and you can't engage in it because of the cost, that doesn't mean that you will get into the scheme. If there is a medication that you haven't taken that can possibly provide some solutions to your symptoms, because you don't want to be on that medication, you don't like the side effects, then you will not necessarily get into the NDIS. So treated and stable are quite complicated and contested spaces. So once you're in the scheme, you have a planning meeting and funds are allocated through that process in response to identified goals. So participants will identify goals and funds are associated with those goals. So what would you like to be doing and what aren't you managing to do currently? And these plans are reviewed annually once the funds are in. Supports are then purchased by the participant or someone acting on behalf of the participant by creating new markets of providers competing in a marketplace. So that's where the marketplace comes in. Next slide, please. So the NDIS argues that it gives individuals choice and control to purchase supports, creating new markets. And some of the key questions that for me need to be answered in this space as someone who does informal care and support include: how are the markets of support managed and distributed? So where do they arise from? How do people access them? Where do informal supports sit in these markets and what is their role? What does market competition do to the collaborative work of disability organisations and their capacity to support families and carers? So organisations that may have once worked collaboratively are now in competition with each other. So that idea of shared resources, shared programs is much more contested and difficult. And in the mental health space, that's been particularly fraught. Are carers' needs, rights considered in the new competing market of supports, and how? So where are carers' needs positioned in this new landscape of support, if at all? So this slide, next slide please, this slide talks to the positioning of informal supports in the NDIS. So this is where I've started to unpack in my research where carers are positioned, and I've done that through a number of techniques. I've done a discourse analysis of key legislation and the processes and instruments involved in the NDIS as it goes through planning and so forth, and where carers are positioned in that and how they're spoken about. I've done field ethnography in community organisations to see how they're responding to this new landscape and how they're supporting carers in those. And then interviews with carer support workers and advocacy staff, as well as carers themselves. So out of all this, I've found that, for instance, carers are identified as partners in support with government, so they're seen as kind of equal with the people that govern this scheme, sitting outside this scheme and collaborating with very highly paid bureaucrats in supporting a participant. Carers are assumed to be providing sustainable and reasonable and necessary informal support, so the term reasonable and necessary comes up, but it's not really unpacked at all. They're assumed to have less to do once an NDIS plan is in place, and one of the arguments for the NDIS was that it would free carers up to return to being productive members of the community, so maybe the possibility of returning to paid work, because we know carers are highly underemployed in the paid workforce. They're provided with limited carer-related supports through the NDIS and only as they relate to the participants' needs. So this could include psychosocial education or family therapy or learning about the illness or the disability, learning how to manage it better in the day-to-day, learning about the medications and treatments that were available and so on. So very much focusing on the disability and the participant. Carers receive no assessment of their own in this process of what is reasonable or sustainable alongside the participant's plan, though this was advocated for and it was argued for in terms of, well, we need to make sure that what we're asking of informal supports is reasonable, and that hasn't happened. Carers are also assumed, it's also assumed that carers' interests align with the participants. And I think this is a tricky one because sometimes the participant's doing okay and their plan is going well, but the carer isn't necessarily finding that their own needs or their own desires to return to other things are being met. So they're not always in sync in terms of their levels of satisfaction. And that quote from the NDIS, I think, sums it up also, that families and carers provide help and support that would otherwise be provided by formal services or paid support workers. So there's a clear statement, don't know if you could state it any more explicitly, that families and carers are seen as an unpaid employment resource, which I think is interesting. Next slide, please. So here are some of just a few vignettes of experience from my research. I won't be able to unpack them too much, but they'll illustrate a little bit that the trickiness of this space. So first of all, Julie, who's been advocating for her son, trying to get changes to the plan. If you're not happy with your plan, you can go to a tribunal and have your decisions reviewed and your funding reviewed. And she's done that on behalf of her son 3 times or 4 times. A very bureaucratic, a very actuarial and legalistic process. And she said that through that, her son has got a pretty good deal out of the NDIS, but it's broken her. She's absolutely exhausted by it. And then we have Laurie, who's parenting 2 young adult children in the 18 to 22 age group with dual diagnoses. And she talked about how it was like running a small business in the background of her life, coordinating all the workers, making sure they were finding which programs were available, mapping out the week, getting feedback from treatment teams, taking them to appointments and so on. And her feeling was that first, the house is not my own anymore. There's such a cycle of people coming in and out rather than the person going to community support somewhere else. And also that she spoke about how my life is all NDIS this and NDIS that. And finally, Margaret, who's a young carer for her father, and she talked about how she was anxious about the plan going well, and if it went well, that at review they might reduce the funds that had been working, which does happen, and did happen for her, and also if it's not going well, that it could actually directly impact the well-being of her father. And she spoke about how it made her really anxious and that she can't return to full-time work with confidence because there's this uncertainty about whether the plan would come through and be changed, and therefore she'd have to adjust. And I think when the scheme first came out, there was this sigh of relief because there was this notion of it being lifelong supports, and people didn't read the fine print that every year it would be reviewed and could be changed. So a lot of carers have found that uncertainty really unhelpful. Next slide, please. So some of my emergent findings. The NDIS outsources complex administrative system processes to individuals or their carers if they're not able to manage that themselves, and this increases the care work for people in the scheme. In thin markets, such as regional, remote, poorer, informal supports are expected to take more of the load. Carers are unwell and ageing, and we all know this. And the market of the NDIS doesn't address these systemic issues. And I think Doreen's quote on the left sums that up, where she says, "I need a plan for when I am too old to do this." And she laughed, of course. There is nowhere in the NDIS for that conversation, and she is 83 years old. The most vulnerable and those with highest need have the least resources to navigate and advocate in the NDIS and the marketplace. So it's very much a system that benefits people who have education, who are confident, who have the time and resources to collect the evidence that are needed to prove disability, who can go and advocate in a legal frame, and who understand the language. So if their language is English rather than English as a second language, there's a whole lot of ways in which people who are the most vulnerable or disadvantaged in the community are made more so through the design of this marketised scheme. And carers' responsibilisation precludes their own rights and needs. So often carers are being left with a feeling of immense responsibility for making this work and for being informed and for being on top of what's going on and making the right decisions in terms of which providers to choose in the marketplace. And that process is detracting from their own sense of what they might be needing in the in their own lives and what supports they might need to manage their own health issues or to change out of what they're currently doing because it's not sustainable. Maybe they want more time with other relationships, any of the legitimate reasons why you might want to reduce your care load. Next slide, please. So I would argue with the NDIS and with marketisation, and I think this is where we need to look at the granularity of it. What does it mean and how is it applied? How do we create these markets? Marketisation is not a neutral process, and it can be highly exploitative and an agendaed one. And carers' labour is co-opted into the market often. And I don't think that the NDIS is the only place in which this is occurring. And I think we need to look really carefully about that from a carer's rights, but also from a feminist perspective. And I think the quote from Leslie is really interesting because here she is not part of the scheme, so she doesn't know what's in her daughter's plan, and therefore she was there cleaning her house. And there was actual funds in the plan for that to be done, but no one had told her because she didn't have access to that information. And she's 72 years old, so that is not a reasonable thing to be occurring. So the invisibility of carers, I would argue, and their lack of voice is experienced as a kind of systemic violence, and I don't use that lightly, but people are feeling more marginalised, more under the pump, a greater sense of responsibility, more uncertainty, and also developing their own health needs as part of all this. So the NDIS and its individualisation, its individualism exacerbates this. It's hard to have collective conversations about what's going on. It's hard to share stories around how to improve the system. So, and finally, any questions? So I'm happy to talk about my own research, which goes into a lot more detail and is sort of interested in the relational dimensions of the identity of the carer and the way in which the carer identity is highly problematic, and schemes like the NDIS seem to entrench that, not challenge it. So I'd love to hear from people if they're interested in hearing more about my research. And next slide, there are some of the selected references for my paper. Thanks very much.
And our fourth and final paper is by Tamara Daly, and it's called Above and Beyond, Gendered Austerity and Comparative Wage Theft in Long-Term Care Work. Thanks, Tamara.
Hello, my name is Professor Tamara Daly, and I'm at York University in Toronto, Canada. Today I'm presenting a paper on behalf of my colleagues entitled Above and Beyond, Gendered Austerity and Comparative Wage Theft in Long-Term Care Work. So my colleagues are Sara Charlesworth, Ian Cunningham, Donna Baines, Deb King, and Wendy Taylor. Next slide, please. So this slide represents the Decent Work, Good Care project, and our overarching focus for part of this study is looking at state policies, so including funding and employment regulations policies, and the ways in which these are operationalized through organizational practices and work design, and how these shape the experiences of decent work and quality care on the front lines of aged care. Next slide, please. We're particularly focused in this paper on wage theft in context, and the literature defines wage theft in three particular ways. The first is a focus on the workers who experience wage theft, and it includes teens and migrant and temporary workers, as well as refugees, those who have been reclassified as independent contractors or part of the gig economy, and low-wage workers. So we're on slide 3 here. The second theme within the literature is a focus on employers and organizations and the ways in which they engage in either lawful or unlawful means. So lawful means to underpay wages or unlawful ones in order to steal wages from employees. And the third focus of the literature is on the ways in which this can be redressed. So through regulation and standards deployment, as Fine and Bartley point out, through court challenges, community and government coalitions, community labor coalitions, or also through silences where it's not reported and no actions are taken. Next slide, please. So if we understand wage theft in these ways, it's the unlawful non-payment and underpayment of wages. It's also legal underpayment and non-payment by employers, and this is made possible by gaps in employment regulation and also through inadequate enforcement. And there are more insidious forms of it, so it can be in the form of unpaid overtime or even in terms of bankruptcy, where it leads to the theft of pensions. If we look specifically at care work, McDonald and colleagues point out that we need to really understand the funding context and the state funding context in order to best understand what is meant by wage theft. So if we look then, and we're on slide 5 here, at aged care work in context, the funding context for aged care work is one where there's state underfunding of the sector and leads to a lot of austerity. And for many countries that are industrialized and have welfare state policies related to care work, there's a high proportion or a high degree of private out-of-pocket payment by those receiving care services. There's also a high degree of profit-taking by providers of care work services, in particular for-profit providers. And we know the sector to be highly gendered and highly feminized labor force. So next slide, please. So if we operationalize this notion of wage theft, we can think about it in terms of the relationships between unpaid and underpaid workers, the working conditions within for-profit, nonprofit, and public provider organizations, and employers who then use legal or illegal means to not pay workers for their labor time. And this is set within a context of state regulation, enforcement, and funding systems. So next slide, please, slide 7. So thinking then again specifically about aged care work, its poor working conditions are accompanied by chronically low wages, and these in turn result in poor outcomes. So there are outcomes at the care sector level, and these involve difficulty recruiting and retaining workers and an understaffing overall, but also at the level of care workers themselves, where there's high rates of turnover, there's high rates of burnover, illness, and injury. And on a part of care, aged care recipients, there are poor outcomes as well. So we think about poor quality care, rushed care, and not having enough staff to provide the care that's needed. So next slide, please. When it comes to wages, states have intervened quite directly in terms of wages very recently. So in New Zealand, we have the equal pay settlement that is related to both home care and long-term care. In Scotland, the real living wage intervention. In Canada, in the province of Ontario in particular, we've seen an investment in personal support workers to raise their wages above the minimum wage. And in Australia, recently, the Royal Commission into Aged Care Quality and Safety has recommended that wages be improved based on work value and or the notions of equal remuneration. So slide 9, please. How can we understand wage theft then if we're thinking specifically about care work? Well, we posit that there are 2 constructs that are needed in order to best understand the context within which wage theft occurs in care work. And the first is gender, and the second is austerity. So we're relying here on Connell and Connell's notions of the gender order, gender regimes, and gender relations, and specifically the ways in which the gender order and gender regimes within an institution are both aligned in care work, and that these reproduce patterns of social relations that serve to configure our gender arrangements. And that these gender relations get made and remade in everyday life, and they're constituted in routine interactions, and that people then behave in ways that are according to their presumed sex category. And we'll see this in where we discuss ways to provide good care, or what it means to be a good carer. We also would like to suggest that austerity provides a really important construct to understand wage theft in care work, because austerity reveals the ways in which there have been cuts to public services, or there's underfunding and marketisation and outsourcing and new public management techniques. Also, the ways in which there's allowing profit taking, and this increases the pace or the rush with which care work is happening. And also the ways in which employer practices lead to wage theft, and that these are strongly shaped by gendered norms of unpaid care work and the design of public care systems, so that you can't separate out the way in which we expect gender to be performed and the way in which care work is funded and remunerated. So next slide, please. So this particular paper, I'm drawing on two studies. The first is an Australian Research Council study, and the second is a Canadian Institute for Health Research funded study. So both rely on similar strategies in terms of their sampling and their rapid team ethnographies that were deployed. The ARC funded study included sites in Australia, New Zealand, and Scotland, and we did complementary work looking at good quality work and good quality care and the relationships between the two, looking at the Canadian provinces of Ontario, Nova Scotia, British Columbia, and Alberta. And you'll see there's a high number of key informant interviews that have been completed for both studies, as well as work observations that have been completed by a team. So in terms of our findings, one of the things that is very clear looking across all of the sites and all of the jurisdictions is that austerity is leading to understaffing. So we have a situation where underfunding in the sector leads to understaffing, and understaffing itself leads to rushed care and too much workers having too much to do in the time allotted to do it. And so this Alberta licensed practical nurse says there's not enough money for this facility, and they want the politicians to get off the checkbook and come on over. And here they're talking about the way in which care recipients deserve better care, because we don't want to rush these people, and they don't deserve that. But sometimes I feel just too rushed. It's just too rushed. And this notion of the rushing, once again, reveals the way in which austerity plays itself out. So we have austerity leading to understaffing and this rushed care, because there are really too few staff to provide good quality social care. And in this example from New Zealand, the caregiver says, we used to laugh and sing together, but there's no time nowadays. Everything's rushed, rush. All you have to do is get them up and ready for this and that. You don't spend any time with them. So now we're on slide 14, please. In terms of gendered austerity then, and understanding the ways in which gender and austerity go together, we see in these examples that the state is underestimating time, and this is leading to a stretching of the workforce. So if the state is underfunding, they're expecting the gap to be filled on the backs of workers. So in this example from a Scottish Labour representative, they highlight the way in which state funding was for something like £400 or £450 a week. And in fact, it was costing the charitable organisation about £750 a week to maintain the person in the care home. But that the responsibility of the organisation as a charity was like, okay, well, we're a charity, we're going to find the difference. But in truth, it was the difference was found in stretching the workforce and stretching the workforce and stretching the workforce. And then in addition to that, they're talking in the second stakeholder letter that came from a de-identified home care provider about how the care provider, the local authorities are getting the provider to work and paid only like a 15-minute time slots. And then this is then passed down to the workforce, and they're really doing so in a not sustainable way. And it's not allowing for a reasonable set of circumstances or conditions within which to develop care work relationships. So on to slide 15, please. These quotes represent the way in which there's really too much work to do in the time allotted, and it results in unpaid work. So workers are taking it on themselves in order to go above and beyond. So in this example from a recreational therapist in New Zealand, they talk about if they have to start at 8:30, they're actually going to get to work at 7 to catch up. Or they'll leave, at 5 or 5:30, even though they're supposed to end at 4. And the reason for this is that there's a lot of paperwork that needs to be entered on the system on a daily basis. And there's a lot of people to report on. But you see that the extra work is being done in ways that are not meant to take away from the actual recipients of care. So this is extra burden, or the burden of care is being placed onto the backs of the workers. So next slide, please. We're now on slide 16. So gender regimes are also being revealed in the way that there's organizational understaffing with this underestimating of time, because it increases the pace of work and stretching the workforce even further. So in this example, the New Zealand home support worker is talking about if you complain, like, you can get extra time. And then she says, but really it's not going to be okay, because what they're going to say is, okay, you can't do it in that time. So you'll be transferred to the next client, and they'll put another carer on who can simply finish the work in that time. So this has an impact on wages in the sense that if you can't maintain the pace of care, that you won't be able to keep the same client load. So austerity then also results in the ways in which regulatory gaps don't properly govern how certain parts of the labor relationship are handled. So in this instance, it's about split shifts. And here, Iris works 10 hours a day and split shifts, but sometimes she's out of the house for 14 hours because she works from 7 to noon and then 4 to 9 p.m. And she talks about, the stuff that she does during the split, but she says most who do the split shifts sit on the side of the road. She goes into the office. She's a more experienced worker, and she's worked out patterns to sort of figure out how to fill that time. But oftentimes that is unpaid time, and it's time away from home, and also time that can't be made up in other ways. And she talks about the way she lives too far away, so it's not like she can go home for those 4 hours. This discontinuity that results from split shifts also is related to a regulatory gap governing how travel time should be handled. So in this example, this worker also works very long hours, but talks about the ways in which they're not paid travel time when they leave their own home. They only get it between clients. So when you go to your first client of the day, you're not paid your travel time, and you're not paid your travel time when you finish at 2 p.m. You're not paid your travel time when you go back at 4 p.m. or after when you finish at 10 p.m. So there are 4 instances where you're actually traveling to and from work on a given day, and you're not remunerated for that travel time. And so she says, I go to 10 or 12 different people's homes. It's hectic. And they're only paying me for 10 minutes or 5 minutes to get between these homes. That can be stressful if you're driving and you're driving between traffic. So we're on slide 19 now. In terms of gender regimes, also this notion of being available at all times results in you having to take time out of your life that is unpaid. And here we see caring work that is done outside of paid work time. So this worker in Australia talks about how they were initially allowed to go to funerals, and it was considered, they were considered to be representatives of the home. They were paid for this time, and now they go to funerals, but it's in time off, so it's in your own time. She also goes on to talk about the ways in which she has a second job working in a bowling alley in the evenings. And this one time, a resident was brought in by family members, and she was the one to take the resident to the toilet. The family members didn't, because she was there and the resident knew her. But she was not being paid for that time as a care worker. So this notion of when you're working is related to time out of life as well. So in this instance, this particular worker is on call, but it's not paid on call. So they work with an agency as well as their other employer, but they're on call and they can't do a lot of work with the agency. So they could be out earning money, but they're on call and they can't go and do another job. And then in this second example on slide 20 talks about the break time again, and what happens when you have this break time and you perceive it as break time, and you might even schedule your own things in it, but then the office calls and gives you additional work to do between that break time. So you have this funny kind of back and forth between when is it your time and when is it work time. And they talk about here the way in which it was easier when it would just go all the way through, but there's nothing that they can do about it. These split shifts are part of the work. In addition to that, low wages are something that are endemic to the care workforce. And in these examples on slide 21, we show the way in which low wages are associated with something that is a government responsibility, but it's also low wages for the level of skills and responsibilities. So here, the interview with the Scottish care worker talks about how the Scottish government should see their work as just as important as that of an accountant or an electrician, and that they're not really getting the recognition that they deserve. And another interviewee in Australia says, I could work at Aldi for more money than I'm getting if I were to start in care work. One of the other ways in which gender regimes, like within organizations, plays itself out is in terms of unpaid overtime or paying for partial time. So in this example, and this is something we heard repeatedly, there's you come in a few minutes early and you leave a few minutes late each day. So you're bookending your time, but you're not paid for that extra time that it's taking you each and every day. The notion that also care just means that you have to go above and beyond was something that came out in many, many interviews. And here, what our interview with our Australian home care worker is talking about is that providing good care means you go above and beyond, even if it means that you're taking extra time. So this care worker says, I'm probably a little bit different, but we're given a time frame, but I'm not afraid to go over and provide that little bit extra. But then they go on to talk about the way in which a little bit extra is taken out of their travel time. So I'm just taking my time, I'm talking to them, and if I go 5 or 10 minutes over, go over, but I don't charge them for that. I'll get paid for it because of my travel time between one client and the other client. So they're really hedging their bets that they're going to make it to their next place in the amount of time that they can get there. So this notion of what it means to be a good carer then plays itself out in terms of whether or not this Australian care worker thinks if time is too big a focus, that sometimes people who see time and are very rigid about it, they want to take their breaks no matter what. And she argues that to be a good carer, you can't just treat it like a job. You need to treat time in a different way. But not taking a break means that you are in fact donating your own labor and your own work in a way that's unpaid. So this care worker then talks about, most people care and they don't just treat it like a job, but there are a couple of them who do, and they treat it just like a job. And this reveals the ways in which gender norms and gender expectations play out, especially when it comes to care work and care work where austerity has been deployed. So what does this mean then in terms of how we understand wage theft? We think we need to redefine wage theft in light of how we understand care work. So generally, wage theft is the unlawful non-payment and underpayment of wages. It's also the legal underpayment and non-payment of workers. And this happens where you have gaps in employment regulation and inadequate enforcement. But that, as McDonald argues, the care work funding context is vitally important to consider. And that as the examples of Scotland, New Zealand, and those in Canada where we've had increase in wages, and also the findings from the Australian Aged Care Commission show us that wage theft for aged care can happen even in the context of regulatory interventions, and that it's endemic even when governments intervene to address low wages. And what this means then is that the work and time required to provide quality care work has not been fully costed and accounted for as work. So, to conclude, how is it that gendered austerity is revealed? So, we'd argue then that our findings on comparative studies of care work extend to the wage theft construct. We agree that legal and illegal non-payment and underpayment for work is an important consideration, and that institutionalized wage theft by the state underfunding is really important. And to that, we want to add a couple of side notes. That austerity politics result in underfunding, understaffing, rushed care, and too much work to complete in the time allotted, so that unpaid work gets performed as a result of that. That regulatory gaps, such as those that address how split shifts are handled or travel time are managed, result in wages being stolen from workers. That the expectations to care result in time foregone out of life, so that people are doing things in their quote-unquote spare time or their own time that should be otherwise remunerated. That workers in this sector are underpaid when we consider their wages in relation to the skills and responsibility that are otherwise required in order to perform this work. And that all of this is heavily reliant on our understanding of how gender is quite pivotal to understanding care work organization and women's elastic caring. That is above and beyond, and with the expectation that it will fill the gaps that are created by austerity. So, to conclude then, our study investigated wage theft through the lens of comparative care work. And we note that you can't just erase the relational and emotional components of care. It takes time to care. And managerialism and austerity try to erase these things, but it's not possible. So this labor is not erased, but it is made invisible when we don't cost and account for it. And we also institutionalize this notion of above and beyond that is demanded of care workers and places a burden of care on a gendered workforce. Thank you very much. I appreciate your time.
Thank you very much, Tamara. That completes the 4 papers for our session. And now I'm very pleased to introduce Diane Burns from the University of Sheffield. And Diane is going to give us some thoughts about these papers. Thanks, Diane.
Thank you, Gabrielle. Thank you to all the presenters for your insightful talks. I really learned a lot and really enjoyed them. Florin, it was great to hear. Your significant findings on quantifying the effects of pay and training on care quality. And Olivier, really great to hear your findings on seasonality and the effects of seasonality on the home help market and the implications of this for the coverage of provision and the inequalities it appeared to create. Amaya, really great to hear your work exploring the NDIS in Australia from the perspective of carers and actually the alarming effects this seems to be producing in alienating and intensifying the load upon carers. And Tamara, really fantastic to hear your work, your comparative study with colleagues about long-term care and the interesting contribution you are proposing to make to conceptualizing wage theft. So what I'm going to do is present feedback, my comments and some questions, first to each of the presenters about their paper, and then following that, offer some overarching reflections and on themes for us to discuss that I will invite all of the presenters to think about and discuss. Okay. So to Florin and your co-author Stephen, it was a really important aim of your paper to quantify these effects. Of course, anecdotally, we know through talking to workers and talking to other actors in this field that employment conditions have this effect on care quality, and to see your research quantify that effect, I think is really exciting. I wondered if you could say a little bit more about the USA studies to examine this kind of relationship. You quite rightly pointed out at the beginning of your talk that there isn't really many studies that have examined this effect within England. and that has a longer history in the US. So I wondered if you could say more about the findings of those US studies, and also what those findings have established, and perhaps the influence they may have had in developing policy and provision within the US context. My next question is really focused on some of the key variables that you included in your analyses. Your findings show support for a higher average care worker wage and the improvements that perhaps can generate. So of those that you identified, there are the higher wages and also training, and perhaps training that goes beyond that, which is just mandatory. Now, I was reflecting on these two characteristics because they're also reflections of the ethos in a care home, and there's certainly research that has pointed to the way job quality is created and the way care workers are treated is a reflection of the ethos in the home. And by that, I mean a particular model of care that's in operation in the home. And in our own research, where we researched 16 care homes in England, we found that the particular care model in operation within the home, and it could be that the homes are owned by the same company, but they had developed a different ethos within each individual company, and that seemed to have a role to play in the quality of care that was then produced, regardless of this for-profit or not-for-profit status. So my question to you is whether you thought about this dimension in your research, whether you controlled for this dimension, as it is more difficult to quantify something like an organisational culture or a culture of care within a home. And my third question relates to the policy implications you suggest around job quality and how it's important for long-term care, and how the appropriate funding is necessary for staff training, pay and retention. Now, given this evidence that you've presented from your study, would you advocate the introduction of a specific national minimum care wage? So if a particular wage is pivotal to providing good quality care, would you then suggest that there should be a minimum care wage that applies across all care occupations? Thank you. And moving to Olivier. Such an interesting study that's highlighted these place-based fluctuations in demand and supply for home help within this local coastal economy and its effects. And I was really interested in the observation you made about how some of these conditions, the scissor effect, led to rule breaking within the paid care home help realm. Now, reflecting on that and the methodology you use, the ethnographic survey, you spent time observing and even participating in the work with the people that you were researching. And I wondered, because you were gathering this grounded data in realities of those work practices, whether you observed any rule breaking taking place during those observations, and if you did, what did this look like, and what was the workers' experience or accounts of that rule breaking? Did they see it as rule breaking? My next question relates to the economic logic you point out is evolving in this local context, and interestingly, how it's guiding or even perhaps driving the various means through which home help is variously organised and its consequences. So my question is, how do you propose this finding on seasonality and the local economic logic that's evolved from it can make a contribution to the sociological literature? So what does that finding add to what is already known in your view? And my final question, you identified this very interesting tension between the motivations of workers and the tendency for workers to go beyond their contracted roles. Can you say more about how you intend to conceptualise this tension in your paper? Thank you. And moving on to Amaya. As you pointed out, Amaya, there's a lot of research on carers that reveal they carry this heavy load in an unresourced and highly gendered space. And your findings illustrate how the NDIS and its operation in practice is intensifying the load and even extending it. Can you say more about how this reality of the situation for carers compares with the aspirations for better state support championed by carers on the lead up to the creation of NDIS? So what has materialised or what has not materialised that was campaigned for? What is the gap? And can you give any thoughts on why that gap has taken place? In your NDIS findings, it seemed to me that that whole system is imposing new forms of regulations and expectations onto carers, in effect pushing them to perform new and perhaps even more invasive forms of unpaid activity, whilst on the other hand, treating carers in several ways as if outside of the process and as if voiceless. Now, you mentioned at the beginning of your talk how caring, unpaid caregiving, is more than a collection of tasks. It is embodied and a form of powerful identity for people. So given all these detrimental effects and limitations that you've highlighted, how do these affect carer identities now, do you think? Could you say a little bit more about that? My third question is that your research appears to identify a blurring or a further blurring of the boundary between the private and domestic realm and the public realm, with the person's own home becoming a site of public administration and formalised caregiving. Could you say more about that, and if that is your thinking about your findings, and perhaps give some reflections on that blurring of the boundary? Thank you. And turning to Tamara's paper with her colleagues going above and going beyond, you frame your paper through two constructs, gender and austerity. So taking gender for now, you quite rightly point out that gender relations are made and remade in everyday life and constituted in routine interactions, and people are held accountable for behaving according to their presumed sex category. And you also commentated really interestingly that these become visible in what it means to provide good care or be a good carer. I think this is an incredibly important conceptualization, and I wondered if you could say more about the specific female gendered expectation that somehow led to the workers you interviewed in your study filling the gaps in formal care that you identify. Were these gendered expectations visible in the data you gathered, or are they implicit expectations? If they're visible, I'd be really interested to hear more about how in the data they appear. My next question is regarding care workers who go above and beyond. Now, it's widely shown in the literature that workers tend to push to go above and beyond in all kinds of occupations and jobs. I'm really interested to know if you would say care jobs under neoliberalism are similarly affected as other occupations are, or do gender relationships in care shape the effect in a particular way that is different to other occupations? And my third question is about your conceptualization of wage theft. I was particularly interested in the notion of time forgone out of life, proposed by Murray and McCann in 2014. What are your thoughts on whether it might be possible to cost this in economic terms? And I'm thinking here, similar, in a way similar to the way unions in the UK costed unpaid travel time in the UK context. Do you think it's possible to cost in economic terms the time forgone out of life? I think this would be a very powerful thing if possible, and I'm really interested to know what your reflections on that would be. Now I'm turning to some overall reflections and to pose just two themes for all the speakers to think about. I'm going to invite all the speakers to give their reflections on these themes. So we know that the papers focus on paid and or unpaid work, and a theme emerged for me across the papers is one focused on the factors and forces in which people give and receive care. Highlighted across the papers are environmental forces, for example, such as the political and policy landscape, the economy and economic logics, the formal organisation of care and care work, and employment conditions. So within this context, people who give care are highlighted to give more for various reasons. So my question, which I invite each of the speakers to reflect upon, is whether there is a better way to construct the boundary around the giving of care than currently is the case. Is there a better way to do this that doesn't lead to burnout, exploitation, wage theft, low pay? That's my first theme. The second one relates particularly to the variety of the studies and the different methodologies used to examine your research questions. And across the lot, there is just such an interesting wealth of methodological mix and theories and empirical frames. And each of the papers raise extremely important understandings around care economies, policies, the organisation of care and the arrangements and how these are composed. And also the consequences for those experiencing care and also providing and giving care. So my question is focused on how for each of you, given the type of methodology and the type of findings and evidence this produces, how you might draw on that particular evidence to try and generate impact for change, and whether it might be possible to draw across the findings, draw across these different methodologies to try and generate impact, to redress these gaps, to redress the shortcomings and imbalances that you've highlighted and the exploitative practices that you unmask and draw attention to. So, thank you. I'll back now to Gabrielle.
Thank you so much, Diane, for those really interesting and perceptive reflections on the papers. I think we've got a bit of time now for us to have a bit of a conversation about the papers and their themes. And look, I might start just by saying something that struck me about the connections between the papers, and I think it sort of addresses the first theme that you raised in a way about, is there a better way to construct the boundaries around giving care? And given the sort of boundary problems that were raised by the different papers, it made me think about a bigger question about valuing care. And this is, in different ways, I think this is raised by each of the papers. Florin's finding about that, society has to decide what is the quality of care we're prepared to pay for collectively, so that people can have a decent standard of care when they need it, when they're receiving long-term care. Reinforced by the voices of the care workers in Tamara's paper about not having enough time, being so pressed, there just not being enough resources, and Amaya's paper about informal carers being assumed to be a resource but not valued as needing to have a voice and have their needs addressed, their own needs addressed, or their contributions really recognised by the system. And I also think there's a link to Olivier's research, which is about competition between the restaurant sector and the care sector for workers, as if they're it's more or less the same job, in a sense that you just don't need any different skills. So all those things sort of speak to this idea of, how do we value care? How do we understand care work and value it in monetary terms, but also in terms of an understanding of the sort of skills that might be needed to do the job well, and so on. So they're just some thoughts that occurred to me.
Yeah, it is. I absolutely agree. There is a very overarching and fundamental question at a societal level about how care is valued, and I think it becomes distorted through the question of economics. And the response to the fundamental need for care it seems through an economic question, and then we have all different kinds of responses in terms of marketisation of care, which in a lot of ways is about controlling and regulating spend, and the economics of care, and this question of who pays for it and who is ultimately responsible for the well-being and safety of people who are in need and vulnerable. And there seems to be this tension and pushing between the private citizen, the customer, and the state funding care. And so I think in terms of value, there is this link to one of attention or push-pull between where expectation is placed too. And I mean, there are all these push to individualise responsibility and expectation onto citizens and away from the state. And it's really difficult to untangle all of those things, because it seems to me to differentiate and disperse across the system. And so we have patches of arrangements that look very different and look very localized. And so it's almost as if one solution won't solve the problem, because it looks so context specific, I suppose. Olivier's research certainly points to how the local economy and the geography create these kind of small microcosm of the broader problem.
Yes, yes, yeah. And to return in a way to the theme of the theme overall about care markets, just a little indulge me in a little anecdote. I gave a paper many years ago in an economics department, and I was talking about the undervaluation of care, and the economists were sort of, it was like a category mistake because markets value things at their value. So the price of care work must be the value of care work, if you know what I mean. The wage that's paid is the value that it must be worth in the market. Otherwise, it'd be getting a higher price. So if it was worth more, the idea that markets value things at their value in the mind of people who are focused on the economic side of things, it's very hard to get away from. The idea that there might be systematic undervaluation seems to be a difficult idea for lots of people to kind of grasp when it comes to paying care workers.
Yeah. Yeah, I think, that for me, that kind of response sidesteps the issue. Just, over focusing it down to monetary value, when I don't think it's entirely appropriate to apply that economic logic to care. It isn't a commodity in the same way mobile phones are a commodity. So I think it's a distortion of what care is to try and squeeze it into that mold. And also in terms of how markets work, if it is the value is the value, then why is there so much crisis and instability in the system? It's out of kilter. So I don't really buy that on their own, the premise of their own argument either.
The disequilibrium. Yes, that's right.
Yeah.
Yes,
Yeah.
the price value equilibrium.
Yeah, exactly.
Yeah, that's let's throw that challenge out and invite our all the participants in the conference and the people watching this session to think about the issues and how we can either somehow disentangle care from markets or try to tame those markets so that they work better for everybody involved in them. People who need care workers and family members and others who provide informal supports. So thank you again very much to our speakers for today, Florin, Olivier, Amaya and Tamara. And thank you very much, Diane, for your very stimulating questions and comments in our brief conversation. Thank you. I hope everybody really enjoys the conference.